which is in our hands, and we need to take care of this. Some of the common and uncommon problems, even the oxygenator, oxygenation lines, manifold roots. Of course, in the recent past, I've been noticing several of the times they're giving even up to 6 milligram, 8 milligrams, like that they've been giving, and always the activated clotting time comes. So, what is heparin resistance? The definition says if you give, generally we give about 3 milligrams, that is 300 units, international units per kilogram body weight. But if you cross 6 milligrams also and you are not able to get that minimum ACT of 300, like that, then it is called heparin resistance. There can be several causes. The eosinophilic syndrome. This is one thing which we should remember. Hypereosinophilic syndrome can complicate. And then some drugs, maybe some conditions like liver cirrhosis and then kidney diseases, septicemia, even the dilutions in the cardiopulmonary bypass. So, what are we going to do? First of all, I would like to say that we should ensure that it is given in the true lumen. It has happened to us that several times you give even 10 milligrams they have given. They called me and then I said, first, did you verify that your central catheter is in the true lumen or not? They didn't bother. I said, you open the pleura and check. They opened, they found that the central catheter is in the pleural cavity. So we should not take anything for granted. We should ensure step by step whether we have given in the true lumen. If not, otherwise you take it directly and give it in the right atrium and ensure that you have given it, and then make sure it is still there is resistance to it. Then the common thing, as I told you, is antithrombin 3 deficiency. One of the measures suggested is give fresh frozen plasma transfusions, 2 to 4 units. If you give, the heparin sensitivity increases. But ideally, this is not the indication for alternatives to heparin. But heparin allergy or protamine allergy, if you have, you can use alternatives to heparin. But otherwise, in this situation also you can use. The safest thing that we have seen is bivalirudin. Bivalirudin can be safely given. Other things in antithrombin 3 deficiency, but bivalirudin works very well. Sorry. The other common causes of so first I would like to say the other problems which we see are air embolism is one thing, cannulation problems can be another thing, and then so let's come to the cannulation. We first do arterial cannulation followed by venous cannulation. Arterial cannulations, anything can happen. First of all, many of the times we face difficulty in cannulating for any reason. If you fail first time, then what's the best course of events? The best course of events is probably you can try one more time carefully. But I have seen very senior surgeons, even now, Dr. Nasser, with whom I worked, he is at 65 like that. He typically puts a Cooley clamp and then verifies the purse string, centrally makes a clear incision, puts the arterial cannula in true opening site, and then removes the clamp. So this is the safest technique. Do not fiddle around 2 to 3 times, 4 times like that in the same place using several techniques. So the cannulation should be proper. For that, the safest principle is try once, otherwise make sure you put in a clamp and verify any adventitial fibers coming in way. Don't force into the aortic lumen. It can go into false lumen, it can dissect. So the most important thing is once you connect it, as they have mentioned our senior earlier surgeons, ensure that the good swing is there, you are in the true lumen. True lumen is the most important thing. And if any time perfusionist says that the line pressure is high, do not ignore it. It happens very commonly in pediatric patients. You cannulate the patient, they say it is good, line pressure and all, but you clamp it, suddenly they say, now the line pressure is high. So it is very small babies, the aorta is small, your cannula can touch here or posterior wall or can go in a wrong direction. You still have to ensure that the cannula should be in the proper position, line pressure is good. Don't ignore these things. And then peripheral cannulations can go in many ways wrong. Nowadays, minimally invasive surgery is a fashion. So arterial complications with femoral artery are a very common thing, particularly these aortic surgeries and TAVR programs we are seeing. They tearing of because it is a big size cannula for a small size artery. It is easy to cause significant damage, particularly when there is peripheral vascular disease. So the complications related to arterial cannulation should be kept in mind. And then venous complications. Most important thing is, they say, inadequate drainage. Leave alone the purse strings causing tear, that and all, already they have discussed. When you loop around the SVC, IVC to snare, you can injure the SVC, IVC, or while placing the retrograde cardioplegia cannula, there is a chance that you may, not careful, you can perforate the coronary sinus. Particularly in redo cases and where there is this right atrium is, in certain cases like Epstein's or some other complicated cases where the right atrium is dilated, stretched, the veins can be very thin, papery thin. In redo cases also, you should be extremely careful in handling this. Another thing is the right atrium, after you go on bypass, the right atrium is still full, the PA is still full, and then the perfusionist compliance, there is inadequate venous drainage. It looks as though we have cannulated properly. So we should ensure again step by step. Did we cannulate the SVC properly? Is it going into, instead of the SVC, is it directed one way and is not draining adequately the innominate vein, or is it into the esophagus vein by any wrong thing? Another thing is into the IVC cannulation also, easily we will go into hepatic veins. So we should ensure that it is in the IVC, and particularly so if it is atrial septal defects and all are there, you put in a straight cannula, it may go into the into the tricuspid wall or into the left atrium, and then when you snare it without realizing and open the chamber, you will have an airlock. So we should keep all these things in mind and then do this. And then as I told you, low venous return can be because of kinks, low volume, airlock, and then small size cannulas. You can temporarily try by increasing the height of the table to get better drainage, but we should ensure that it is adequately drained. PA is empty, RA is empty, like that. And then femoral vein is definitely much smaller than IVC. So when you are going through femoral cannulation, venous cannulation for a minimally invasive surgery, obviously the cannula may not be adequately draining it. So this also we should keep in mind. For that, they use a vacuum assisted drainage. It has its own complications, particularly if there is pressurization, it can lead to air embolism. Persistent LSVC is one of the common things which maybe an adult surgeon also majority of the times may not be fully aware as to how to handle it, particularly in the early period of their career. First of all, how do we suspect it? We suspect it when you see in the 2D echo. We should have the habit of seeing personally the 2D echocardiogram. Secondly, when we open the sternum and you see that you don't find the innominate vein, that means there is a possibility of, or a very small innominate vein, there is a possibility LSVC is present. So what are the implications? If you are doing any surgery, then we have to, sometimes we can manage by simply sucking it, but it is a cumbersome thing. It can cause a lot of flooding into the field. So if you want to cannulate, best way to do it is try and dissect it extrapericardially. Before even you open the pericardium, you find it nicely on the left side, you dissect it, but ensure you are taking care not too much dissection with the diathermy, because the phrenic nerve will be almost running on the LSVC. So ensure that you don't injure the phrenic nerve. You loop it if you want, and then once you go on, the cannulation options can be a separate cannula. But if you put a double Y and SVC, IVC, and then third cannula, it will be complicated. Simply ask them to give a 1/4 line from the cardiotomy sucker line like that directly to the venous reservoir. Connect a separate venous cannula into the LSVC. That's the safest thing. You can do it directly from the after opening the right atrium, but that and then pass it across onto the highest possible position and snare it above from the extrapericardial site. So these are another important thing is that in the presence of LSVC, it is probably contraindicated to give retrograde cardioplegia, or you should be. I think there is no proper way of definitely identifying whether you are giving into the coronary sinus or whether you are giving into just into the LSVC. Another thing is, if there is a primum ASD or such kind of defects, endocardial cushion defects, when you are, if there is an LSVC, if there is ordinary coronary sinus drainage, you may leave it to the left side. But this, you cannot do this mistake if you have a primum ASD or anything like that with an LSVC, because the drainage of half the brain is coming into the, and then it will cause a lot of desaturation. Then, once the other two major problems are, one is air embolism, the other is iatrogenic dissection of the aorta. Air embolism, it's regrettable because it is iatrogenic. The brain is the most valuable organ. It is a sensitive organ. It will easily get damaged. Permanent neurological damages and sometimes death can happen. And majority of the times we try to not to report it for the fear of litigation. We know there are several people involved. So how does it happen? Majority of the times there are so many checks and things, but for the sake of cost and in general, in Indian setups, we have seen we are 10 to 20 years old machines we use. We don't have all the panels. We don't have the bubble sensors, level sensors, cost cutting measures. These are all the dangerous things when you look at the life of the person as a valuable thing. So inattention to the oxygenator level, and then once you release the cross clamp and you still think you want to de-air the heart, you realize there is some air and you want to aspirate the heart or something, if you find, and suddenly heart starts beating, it may go into aorta also. Several things, as I told you, the venous reservoir or negative suction to the cardiotomy, when you use a assisted venous drainage, it can cause a lot of negative pressurization, and it can air can go into other chambers. It was done by my assistant, and then we finished the surgery. We just about to remove the root vent or cardioplegia cannula, and then he has to remove the cannulation. Then something happened. I heard the noise like that. We asked, nobody answered. Anyway, we had suspicion you can stop it, you can only prevent it by taking due care. So what happened next day morning, as usual, the girl didn't open eyes. And then it took 3 weeks for us to manage. So massive air embolism is a disaster. Unfortunately, it happens for the most unexpected cases like ASDs, where a junior surgeon, junior perfusionist, junior nurse, everything junior with inadequate knowledge will try to do it. Sometimes it can happen. So we should ensure and take enough care. So how do we manage that? In case if you notice something, first of all, the minute there is an air bubble or something like that, we should stop the pump. Put the patient in Trendelenburg. If you can, immediately put in a retrograde SVC cannulation, like you connect the arterial line or something, from the arterial line a line to the SVC, retrogradely perfuse, and then allow the air to come out through the aortic vent or stab incision. And then even you can intermittently occlude the carotid arteries, because by occluding carotid arteries, you will allow the vertebral arteries also get deep. Then also Hyperbaric oxygen therapy is one of the decompression chambers. This is one of the therapies. This is a retrograde cerebral perfusion which I am talking about. Whenever you notice that too much air has gone, even into the coronaries, they say retrograde coronary sinus perfusion can help in removing air from the coronaries. So this we should ensure. How to give all these techniques are similar to our retrograde cerebral perfusion, 1 to 2 liters at a temperature which, and hypothermia. Another thing is hypothermia. The fashion is not to cool the patient. A surgeon who cools the patient is considered traditional or old timer. The heart at a higher temperature causes not only damage to the heart, if there is any perfusion problem and you are not attending to it, it can cause neurological problems as well. So these are the drugs. The other thing is iatrogenic dissection. High line pressure, though rare, it is often fatal. It can happen at any place where you put in a cannula, aortic cardioplegic cannula site, at the time of insertion, at the time of removal, while clamping, while on bypass. So attention to the detail and understanding is very important. At least it has happened on 2 occasions in our setting. One time, the root vent is the notorious thing. The purse strings are never perfect. They were just lightly placed generally. And then they remove it, pull it like that, without much attention to the details. It just simply dissects. So what you can do, and these are high risk patients like bicuspid aortopathy, aneurysms, or thin old age patients with sclerotic aorta, all these things. So we should be extremely careful about what we are doing. And then how do we identify it? The oxygenator and there is no reduced venous return also happens because there is no forward flow. And then line pressure is very high. This is the usual 3 things. So for us, what we have to remember is, when we cannulated, did we have difficulty while cannulating it? Or what kind of, when we put in a cannula, several other times I see when the juniors does it, if they don't notice a pulsatile flow nicely coming into the arterial cannula and then like that, if you don't see any blood in the cannula, that means you are in the wrong place. So these are some of the things. And then any aortic valve hematoma, adventitial, subadventitial hematoma, when you see, you should ensure that it should not progress quickly. So you can open at the side of the aortic cannula, any adventitial thing, so that little bit of any hematomas will stop expanding. Another thing is, of course, the transesophageal echocardiogram will clearly tell you what is aortic dissection. And then the management is the standard management. First thing is, when you identify that you have dissected the aorta, there is a subadventitial hematoma, there is high line pressure, there is no perfusion, the first thing is stop the pump. Stop the pump, take 2-3 minutes, but quickly change the true lumen cannulation is the most vital thing. How do we ensure true lumen cannulation? Anywhere, any other place, maybe femoral artery, maybe axillary artery is too far, but if you cannot femoral artery, then even the LV apex is another thing, but the cannula should be placed across the aortic valve. These are the important things. First thing is, make sure you are cannulating true lumen, cool down the patient, and then you do the standard aortic dissection repair. Some of the other problems we notice is, actually there is a problem with the slide, oxygenation failure. Oxygenation failure is not equal to oxygenator failure. So we have to make sure that every connection from the manifold room oxygen is coming, whether the connectors are proper, whether the oxygenation is happening properly, is there a blender problem, is there an oxygenator problem. So once we ensure that the oxygen is coming properly and the blender is working properly, then it could be an oxygenator problem. And your oxygenator failure can happen rarely, but there can be cracks in it. There can be clots in it if you don't heparinize properly, inadequate heparinization. But then when it happens, the only course you have to do is, if you are in the very beginning phase, come off bypass as early as possible and then change the oxygenator. If you are at the end also, you can do that. But otherwise, definitely 2-3 minutes of, they will take easily 5 minutes, but the fastest oxygenation failure, there are several checks we follow. Our industry, our cardiothoracic surgery is now compared to aviation industry, where the checks and rechecks, and then the identifying the problems, solving the problems, all these protocols, standardization of communication, all these were vital in solving these problems and preventing these problems. One of the other important problems is hemolysis. Suboptimal, basically if you occlude too much with the roller, or if you suck too high, or if there is any distilled water contamination or a water contamination, all these things can cause significant hemolysis. Some of the times even cold agglutinin and old blood, all these are a problem for hemolysis. We have to understand that. So these are the long checklist. I don't know. We don't see it in Indian setup. I don't think many all these things are ticked and checked. And then though it is recommended, some of the times we don't have one working properly also. So all these contingency plans to have spare gas cylinders, spare hand cranks, spare oxygenators. This is very vital. At least this is in our hands. I have seen several of the hospitals, when you are doing a one pediatric case, they will get one pediatric oxygenator. It is dangerous, disastrous if you have a problem. So having something in, anticipating something and then having a plan of action, some contingency is the key to prevent accidents. These are some of the problems I mentioned. There can be several, which I think for the paucity of time, I am stopping you. So the broad principles of safety are, whenever you are in a problem, don't try to solve it all alone. Just shout, notify everyone in the room, take the help, and then if you are, as I told you, if you are in the very beginning phase, come off bypass. And then if you are in last also, quickly try and come off bypass. And then you have these backup plans, checklists, proper maintenance of the things, all these things, and simulation and simulation training and mock drills. These are all vital. And then most importantly, I think we should voice out our plan of action and then have a trusted team, build up that trust in the.
Thank you, sir.
I think you can continue to your next talk, myocardial preservation.
Sometimes we understand as I have done everything, I have given all my cardioplegia, but still patient did not come off bypass. Giving cardioplegia is not equivalent to myocardial protection. So every time you cross clamp the aorta, every time you cause arrest of the heart, there is going to be some damage. Most of the times it is manageable, it may not manifest, or it may recover at a reasonable period of time, so that we are not noticing the damage that is caused to the heart. And every ischemia causes reperfusion injury. And what is that ischemia reperfusion injury? If you understand a little, it will help us. This talk is designed for at least first year MCS students. Some of the MBBS and MS students may find it slightly ischemia to the heart. It will result in some kind of damage. The damage can be suddenly loss of ATP, free radical damage, or there is this calcium paradox. They say 3 principles. It can be acute in the form of stunning. That means you are perfusing, but there is no function. Metabolically, it is reversible, but it may take some time, few days. And then there is this no reflow phenomenon. Epicardial coronaries, like post-stenting and all you see in acute PTCA, when they do is primary PTCA, they open the LAD and then they perfuse things like that, but the heart is not functional because the microcirculation gets clogged. The microcirculation is not flowing. So this is the no reflow phenomenon. The other thing in the acute situation is arrhythmias. Arrhythmias are, reperfusion arrhythmias are very well known. But the other consequences are cell death, necrosis, apoptosis, all this. These are the lethal injuries that can happen. So they studied this. What are the causes? So loss of ATP, that is what we will discuss later. This calcium paradox, oxygen consumption, elements of protection, these were studied. What is this calcium paradox? They noticed whenever you arrest the heart, there is still calcium levels are high in the cell, and because of that, this ischemic injury is happening. They try to introduce like this Brett-Nieder solution or HTK solution with no calcium or low calcium. They try to introduce this, but despite that, it still happens. There is calcium, high levels of calcium. Once the heart is arrested, it is in the anaerobic cycle, and then it produces a lot of acid. Acids have to be pushed out. It will be in exchange of in place, instead of calcium being driven out, the hydrogen ion is being driven out in exchange for sodium, something like that complex mechanism where the calcium takes the second priority, all the other things take priority. So still the calcium paradox, like hypercalcemia persists. Another thing that they studied is the oxygen consumption levels. If you notice, at normal temperature we require about 10 ml per 100 gram. It is about 6 ml. On a fibrillating heart, it is about 6.5 like that. But as the temperature comes down, there is significant reduction. In an arrested heart, the oxygen requirement is quite low. And then what are the other protectors that we can think of? Like they thought of doing something to the calcium paradox. They introduced this magnesium to counteract the calcium overload, and then some bicarbonate to prevent acidosis, THAM, mannitol and all to reduce the cellular edema, and some local anesthetics like procaine, lidocaine, they introduced as membrane stabilizers. So this is the broad principle behind the these cardioplegic studies. But before that, let's see what other things have happened before the evolution of concepts. See, it was a very long back. Bigelow is the one who studied that hypothermia protects heart. This is a very important discovery. And then there were people who were doing inflow occlusion. I have seen this also. Professor Cartmill, when I was in the Middle East, he did this. SVC, IVC, you occlude it, and then you cross clamp it, you fibrillate it, you put in a root vent, through that it comes and quickly close the ASD. I don't know, in the present days it is important. Only ASD he could do it quickly, but this inflow occlusion techniques were also used. Later on, the Lilly-Hayes controlled cross circulation has come in based on the Ajay-Venus principle. And then Melrose is the one who gave potassium citrate. But the problem was he gave a very high doses of almost 200 millimoles like that they have given. They realized later on it is not that much is required, 20 millimoles is enough. So then there are other techniques which have become popular, like this intermittent aortic cross clamp, ischemic preconditioning, several interesting words they use. And then topical cooling. They used to dip the patient in cold water. Surface hypothermia was introduced by Norman Shumway. And then this, as I told you, ischemic arrest using intermittent aortic cross clamp. These are but the cardioplegia has taken over, and this is the main cardinal concept of arresting the heart. What is the physiological basis of this? This is based on some, and I don't want to discuss this Nernst equation. Basically what they are telling is, if you have to know the resting membrane potential, they have a formula. So now we know that minus 90, 85 is the baseline resting membrane potential. Once it becomes 70, then the action potential quickly fires. This is because of the sodium influx. Now they have understood how to prevent this sodium influx. So either you keep it at minus 50 or you do something like that. So they either increase the extracellular, see, potassium is inside the cell is low, inside the cell is high, outside the cell is very low. So they introduced give high dose of potassium to make it extracellular potassium very high, so that the sodium potassium exchange also doesn't happen. Some way you have to prevent this step. So there are extracellular methods, there are intracellular methods. Thereby this rapid fire of sodium influx is prevented, and so the heart remains in arrested state. This is the primary fundamental thing. So the electromechanical heart arrest of the heart is the primary idea, and then it gives if you rapidly arrest the heart, it will prevent substrate depletion, and then sustained cooling also helps in protecting the heart by reducing the oxygen demand and flushing out unwanted toxins. And then myocardial edema can be prevented by some other drugs like mannitol and some albumin they are using. And then how do we limit that is the main research, limiting the ischemia and reperfusion injury. And then the cardioplegic solutions, the most famous solution was St. Thomas. There was 1 and 2. They have reduced the potassium content and sodium content like that. So St. Thomas solution is generally given along with the blood in a 4:1 combination at a temperature which is 4 degrees to 8 degrees. This is the similar to extracellular. As I told you, potassium is high. They kept the potassium on the extracellular side high so that it remained hyperpolarized. Whereas the custodial HTK solutions and all, they kept the potassium low. They mimic the other intracellular solutions. Delnido is again extracellular. Now, but Buckber has done a lot of research on this cardioplegia. He is the one who said that blood should be the medium of transport. Blood should be given, in this combination at this temperature. It should be given antigrade. Retrograde also, he is the one who popularized, though Lilja is the first one who used retrograde cardioplegia technique. But these people popularized it. Then they said it could be cold, 4 degrees, like it could be tepid at 27, 28, warm, antigrade, retrograde, intermittent, continuous, so many things, make additives. They introduced several things. But at the end, we should realize either you choose this St. Thomas solution, you give it at regular intervals of 20 to 25 minutes, and then make sure you are very disciplined with it. Or this Delnido offers about 90 minutes of time. This HTK, though we don't, because it is hugely expensive, but it says it offers up to 180 minutes. But still the paradox of calcium paradox is there with that also. We know all these things. I don't want to emphasize that anyway temperature protects the heart, temperature protects the brain as well. Remember that. And then oxygen demand and all are less. We can deliver it antigrade, retrograde, blood versus crystallite. Obviously, blood is the normal medium. So it has the buffer, it has the, nutrients, it has a normal physiological temperature, it is rheologically better. When you deliver it through blood, it is always better. So antigrade or retrograde, I want to say one word. Obviously, when in the presence of AR, in the presence of maybe sometimes severe left main or a very tight CVD, though we give antigrade, if you put your hand, you will realize that there is differential temperature you notice on the individual territories of LAD or circumflex. It means that there is still an unprotected area. Maybe graft plegias and all, if someone is keen on that, it should help. Graft plegia will help in those situations, or retrograde perfusion can also, or a combined antigrade retrograde. But retrograde adding in a CABG will make the tubing and piping, all these things complicated, and too many things come in your hand. Come on your way. If it is mitral stenosis with the AR, the LV distends and becomes like a balloon. You have to put some across it, protects. Antigrade, retrograde combined is better. Okay. These are all the ways in which biological markers they assessed that but how do we assess a blood level of troponin T and say it has come from coronary sinus? So unless you really collect it from coronary sinus, these are all not true values. So to summarize, I would say rapid arrest is most important thing. Cold blood cardioplegia has certain advantages. Combined may be more helpful than this retrograde helps. Warm cardioplegia has its own issues because unless you give continuously, the protection may not happen. Any small incident can cause neurological injury also. We should be very careful. I don't say it is not, it is at least mild hypothermia is neuroprotective. Ventricular decompression is most important to prevent subendocardial ischemia and contractile dysfunction. Thank you very much.
Without the cardioplegia, without the myocardial protection, we can't do any surgeries except for closed heart surgeries. It's not like CABG wherein you can do most of them half-form, right? So the preference, of course, as Dr. Pina was telling, it is subjective. Maybe varies from surgeon to surgeon. Many of them use del nido cardioplegia, and I use St. Thomas for short clamp times, and for long cross clamp times, I tend to use not only protects from rewarming the heart, so that actually whatever plegias you are given should be able to protect the myocardium, and religiously adhering to the timing. When you are using a 180 minutes, but usually it may not exceed 100 minutes. So importantly, cooling that heart with topical solutions is also very important. So usually invariably you keep a gauze over it and put some cold saline over it, not to allow the heart to be dry, look dry. So it warms up with the circulation. Please keep the temperature of the OT also to maybe 18 degrees, so that it will prevent warming. But warm up the heart, I usually only use only the headlight for operating, avoiding the ceiling lights, so that to prevent the warming of the myocardium. So these are all certain finer things. Actually, I think they really matter in protecting the myocardium.
Thank you. Thank you.
Any questions from the audience?
Ready, sir? Dr. Abhijit, sir. Dr. Dhyaneshwar, sir. Ms. Dharani.